Thank you for being here. We are talking today about documentation for trans and non-binary clients, which is something that I know Dana and I have both gotten questions about for years. It used to be more common that I would get questions about it for adolescent clients,
Mhm.
but the last 10 months or so, it has become a lot more concerning for people. And actually, even before then, so Dana, I know you're going to talk about a situation that happened a few years ago now, but with the current administration and definitions changing, rights changing literally before our eyes, it is, regardless of whatever you might believe, those are facts. And so things are changing, and it makes it really, really difficult um, for us as therapists to know how to protect and serve our clients the best that we can. And it's really complicated when we have to make changes for that. So, okay. Dana, so welcome everybody if you are here. My name is Maelisa McCaffrey. I am the founder of QA Prep, author of this book, Stress-Free Documentation. And Dana, I will go ahead and let you introduce yourself.
Sure. So I'm Dana Sia, pronouns she, they. I'm over at CNC Resourcing, offering a lot of trainings, often free YouTube lives as well, just like you all are joining us here today. So trying to do those once a month or so, but a lot of stuff on demand that I've done previously. And most of that comes with MBCC CEs, including an hour and a half training specific to clinical and ethical considerations working with trans and non-binary clients. And that's kind of how this conversation got started between the two of us, was a live that you had done. And then having done my training and finding the overlap, as well as the continued questions, to your point, that come up as things change. They just do. They just change. And so we're trying to adjust.
Yeah, yeah, and some of that is uh, neither good nor bad and just natural, right? Like I answer very different questions that I did 10 years ago, unrelated to all the political things happening right now. Um, and so, I think that's important to remember, right? Like this is a process. And, I think we both want to acknowledge that this also does appear to be, hopefully, a unique time in our lifetimes, in our professional lifetimes, as far as these specific concerns. And so we want to acknowledge that and provide you with tools to help. Um, and I have another YouTube live where I talk about sensitive topics in general. So today we're really just going to focus on um, trans and non-binary clients. But I know that there are lots of other questions people might have about other topics as well. So, I have other resources on this channel that you can check out for those if you want to dig into that. We got a ton of questions submitted ahead of time. So we are going to dig in, and especially since I got us started late. So, but Dana, did you want to talk about this kind of original thing that happened in 2022 with the university giving up records? And because that, like I want to point out, is unrelated to what is going on today politically, right? So this is not, while this situation is unique right now, it's also not unique, right? Like these concerns have been ongoing.
Mhm. Mhm. Sure. So I think, and you make a good distinction there between what happened in Tennessee, which was when the Tennessee Attorney General, and as far as I know, this is the first incidence of this happening. So the Tennessee Attorney General used a fraud investigation to go to Vanderbilt University Medical Center and request records for their trans and non-binary clients. That included mostly adults, but it did include several minors as well. And as you can imagine, the patients were very concerned about what was happening to their information. And they actually didn't find out until this hit the news. So they were finding out the same time that we were finding out that this had happened. And I think the worst part of it is not only was the request made, but Vanderbilt University Medical Center pretty much released the entire medical record of all of those individuals. So there wasn't much that was de-identified. Their like personal information was on there. And so their concern was like, where's this information going to go? What's going to happen at the Attorney General's office? Who else might get a hold of this? And like I said, this was what seems like the first instance of it. It happened in 2022. There are additional states where this has also happened. Very similar attorney generals are asking certain medical organizations to release those records. And now, what we're seeing in the last year, few months, the Department of Justice is doing the same thing. So they are using the same type of fraud investigation language, which is a civil demand to request records from primarily larger organizations that are providing care to trans and non-binary clients. I think the concern with the Tennessee case was they didn't just ask for the patient's information, they asked for potential patient's information. So, like when we
Oh
have
my
a
gosh,
consult,
I didn't know that.
yes, they asked for anyone who had done a consultation on potentially receiving services. They had also asked for information on volunteers that worked in the clinic. So it's we don't know to this day what has been released, but I think that is what touches on all of y'all's concerns. Who can ask for what? Who can they ask it of? What information can they get? And what happens to that information? And while there are still a lot of unknowns, we have learned a lot from what happened in Tennessee.
Awesome, awesome. Do you have a couple of points there about what we learned from Tennessee? Or do you want to dig into the questions and kind of answer through those?
Well, I can touch on with Tennessee, our government did kind of approach that and say like, what did you do? Like, why did you do this? They were kind of asking the same questions I think many of us are asking, like under HIPAA, you probably should not have released everything. Like there are actions you can take to prevent the release of information, and even further actions you can take to decrease the level of sensitive information if you are required to hand it over. But we don't know what all was turned over. We still don't know. So there have been several states since then, as I mentioned, who saw that as an example to be like, let's not do that. These organizations who are being requested by their state attorney generals are pushing back. So I think some good has come of it because Tennessee, the Vanderbilt University Medical Center was made an example, but it still doesn't like make any of us feel better.
Got it. Yes. Yeah. And I think that's a really key point, right? Is number one, HIPAA always requires minimum disclosure. Like, yes, if you're receiving some kind of oversight from a government entity and often from insurance, you might have to comply with something. But even within that, that doesn't mean that it has to be any and everything. Um, and there are steps you can take to kind of delay to respond. You can't ignore requests, but yeah, you don't have to just immediately reply with here's everything that you requested. So that's good to hear that um, other organizations are using that. And even as like a small fry, if you're, a solo private practitioner, you can use that same method. Don't ignore, do acknowledge, but ask questions, clarify, do the minimum necessary first. I have heard an attorney, so there's an attorney who's also a licensed counselor here in Washington State. And, a lot of times I've heard him give the advice that you can always give up records later if you're required to do so, but you can never not give the records if that was your first step, right? So it's always better to not regret necessarily, but like if there's a delay, that's okay. People can get their records later if it's necessary. Um, but you can never take it back if you've already given up records. So, always kind of defaulting to slowly addressing that problem. Yeah.
Mhm. And to your point about the subpoena, like it is an option. I see it go around. I'm sure you've seen groups, especially Facebook groups, where it's like, just don't respond to the subpoena. And the problem with that is like, you're going to give up some of your rights as a healthcare provider. So some of the rights that you had in responding to that subpoena, in protecting your client's data, you give up those rights, and it could lead to a doubling down of the entity who requested the subpoena in ordering you to provide even more information and to make it more strict. So ignoring it is an option, but it's really not a good option. So always get somebody like an attorney to help you in responding. Essentially, don't respond on your own. Always get somebody who is knowledgeable about healthcare, legal ease, if you will, to help you respond to that. Because if you don't, then it may get even worse.
Yeah, and in your state. And this will be my plug. I like to remind people, most of you, if not all of you, with your malpractice insurance, your professional liability insurance, you get a free, at least one free consult with an attorney. And so use that, if you ever get something where you're like, do I need to release these records? What's going on with this? Yes, use that consultation. And it doesn't mean that you have to now start searching for attorneys and pay a lot of money for representation. Use the services you are likely already paying for. You have access to that.
Mm-hmm. Yeah.
Awesome. Well, should we dig into questions? Because we have a ton.
Yeah.
And I think Dana and I could do a whole, looking at all of our notes that we prepared, I think we could do a full day training on this.
Mm-hmm.
So we will get as many questions answered as we can. And if you want more and if you want CE credit, you can check out Dana's course. We will have a link to that in the description of this video. But do you want to like give the website again, just in case people want to go straight there?
Mm-hmm. Yeah, it's learn.ccresourcing.us.
Awesome. Cool. So you can go there. And I know you have other courses too, but if you're concerned about this particular topic, you can actually get CE credit for a legit training on it. So go for it. All right. So we have kind of organized the questions that we've gotten based on category. And so we're going to answer them category by category. So the first one is going to be government and other oversight concerns. So we got questions about like insurance, Medicaid, things like that. Then we'll go into actually would probably be a quicker section on using pronouns and kind of general language and documentation. And then we also got a lot of questions about technology, AI, using an EHR versus paper, and keeping clients' privacy based on that. So we're going to start off with kind of these general government and oversight concerns, because I know, Dana, you address a lot of the other questions in that course that you have. So these are things that are changing. And so if you're watching this recording in 2 years, I don't know if what we're about to share is 100% accurate. So keep that in mind. And always, consult with an attorney, stay up to date, take trainings based on your state, all that kind of stuff. But to dig in, our first question is, can you confirm what power they, and by they, this person was kind of referring to, like, in general, the federal government, and HIPAA, like based on HIPAA regulations, are currently leveraging, and if leveraging their power, and if there's concern about an escalation of abuse of power. And did you want to start off with this one, Dana? We'll just get right into it, but you've already kind of alluded to this point.
Right. Yeah. So the state and federal, these are all fraud investigations, and this is considered a civil demand. And you will find that in HIPAA, where if you have a civil demand, that you should release records with these caveats. And so HIPAA kind of has listed in there the caveats, I think the most important of which is to decrease the amount of sensitive data that would be released if you respond to that civil demand. So there is that piece of HIPAA that says, yeah, if you're being requested by a government, by a law, by an investigation, you do have some responsibility to respond to this and make sure that you are protecting the patients and clients first and foremost. I think we often see these, and not wrongly, we often see these investigations as investigations into the patients or clients. They are brought about as an investigation into the provider. So I think that's an important distinction to know.
Yeah.
Um, when would these come up? Related to Medicare, Medicaid, state, and federal funds. So if an organization is receiving those funds, from state or federal, then that's where the fraud investigation comes in. Are you using these funds correctly?
Right, right. Yeah, and it kind of dig into that example, like we could use Medicare, right? So if someone is, if Medicare is paying for someone's therapy, really it could be either one, right? So if this happens a little bit more with private insurance, but it does happen with Medicare. If someone is using their insurance a lot, insurance is invested in having them use their insurance less or having them use their insurance more efficiently and essentially more cheaply, right? So, and that's kind of in general for all insurance companies. And so it could be based on the patient or the client where they say like, oh, we see all this billing, we see all these needs. Is this person actually getting their needs met appropriately, right? And so they do an investigation, like a fraud investigation um, or even just an audit to determine that. Or it could be based on you as the provider too, right? Those are two different reasons that you could get an audit. Those are two different reasons you could get some kind of oversight investigation. So that is important. I really like that you made that distinction. Um, because for example, if there was some oversight complaint, like let's say your client complained to a, you know, a body like a licensing board or made a complaint about HIPAA or something about you, that's very different if the client has initiated that and is essentially seeking for some outside entity to help them against you as the provider, which unfortunately does happen. Um, that's very different than if the entity comes in on their own and the client is unaware, right? Um, so yeah, thank you for making those distinctions. That's very helpful. Did you have anything else you wanted to add before we go on to the next question?
I think we covered it well. If folks are watching and have additional questions, feel free to put that in the chat and I've got it pulled up so we can check that. But yeah, I think that we covered that pretty thoroughly.
Cool. Awesome. All right. And next question is, are there any concerns that insurance companies will hand out documentation without client or provider consent? If so, which insurance companies should we be mindful with? I don't think we're going to speak to specific insurance companies because um, results will vary. And essentially, they all do have the same rules and laws around that, around whether or not they can and should and how to request documentation. So I don't know if you wanted to take this one first or if you wanted me to do it first.
Yeah, I think without, I don't, to your point, there's not like a direct answer to this question. The concern is anytime any like program or entity holds that data on clients. So this could be an insurance company, it could be an EHR, it could be programs that are used by an insurance company, maybe not the insurance company itself, but essentially anyone that or any organization that could fall under HIPAA could be held to this type of investigation. And that's where it kind of comes back to like, yeah, HIPAA allows for that release, but there's also the requirements that you decrease the amount of that information that is released.
Yeah, thank you for that. Such a good point. It really is. Even I will sometimes get into like insurance is different. And really, it is. Anytime you get any request about a client's records, you really proceed the same way, regardless of who it is, um, at least with the first steps. So, yeah, and I would add to that that I think it's helpful to always take a step back and remember that when it's insurance companies specifically, 99.9% of the time for them, it genuinely is about money. And that can be helpful to remember. While it might feel a little icky, it's actually very comforting to know that when you're dealing with an audit, because if insurance companies are requesting documentation, honestly, they are here for profit. And it is far less about political things with most insurance companies. It really is more about profit for them. And so they're going to do what is profitable and they base audits based on that. Um, and so if you do get a request from insurance, it is far more likely to be related to the fact that this might be a client who is using a lot of their medical services, right? And for the insurance company is like they are paying more or seeing more billing for this person. And so that is really, I don't know, that's just a good reminder, I think, that often is really what the concern is. Um, and I have, and insurance companies, as far as I know, are not actually, I'm realizing this, it's a little different from audits, like handing out information about clients without consent, but I would assume that most of us have signed some kind of agreement with these companies saying that they could. And I would never assume that an insurance company is um, protecting my privacy above their profit. And I would never assume that as a person who uses insurance, right, as a client or as a provider. And so, yes, with insurance, again, I think people often also have this feeling that like insurance knows about your notes or something like that. They only remember they only see what is on billing claims. That's the information they have. They don't have access most of the time to your progress notes, for example, to your full intake assessment, right? They have access to diagnosis, amount of, what type of billing you're doing, how often that's happening. And so often they don't have the more sensitive data um, that might be more concerning for you. So I think that is a little comforting as well, unless you give that to them, right?
Right. And what you brought up for folks who are maybe newer professionals, it's a big difference between an insurance audit and a fraud investigation. So the fraud investigation being initiated by government, attorney general, and then the audit being initiated by the insurance company. So you've got a different contract with the insurance company than you're going to have as far as like your legal obligations for a fraud investigation.
Yes, totally. And you're much more likely to deal with a fraud investigation if you are working with a larger entity. Um,
Right.
and that can even be like a large group practice, a small clinic, that kind of thing. And unfortunately, I have seen like fraud does happen.
Mhm.
And so it's not that these fraud investigations are completely nefarious. These things do actually happen. It is not that common. It is far less common, I think, in our profession for mental health than it is in some other professions. But it does happen. So, and usually those still are going to be triggered by billing information. So being good about your billing, being accurate about it, um, will often just ward off all of those concerns. All right, let's go to the next one, which is this is our last question about governance and oversight. Could you confirm if these risks could impact those in small group or solo private practice, and the risks about government pressure on insurance companies? So we've kind of been talking about this a little bit. Yeah.
Yeah, leads right into this topic. I think your risk, regardless of size, is going to increase if you're using state or federal funds for the patient's care. So, again, Medicaid, Medicare, think state employee health plans and ACA plans. All of those could increase your risk of this type of fraud investigation. To your point, the larger your organization, the greater your risk as well. And probably the greater the chance that you're going to use some of those state and federal funds for patient care. So there's probably a graph that we could chart there on like how much funding do you take and how large are you? And like the line just keeps kind of going up to show where your risk is at. But I don't think that anyone is with zero risk of this happening.
Yeah, absolutely. Yeah, that's helpful to remember. Um, But as a solo private practice, your risk really is far lower. But how this might be relevant to you still is if your client is still using some of those other services, right? So they may not be using those services with you, but still involved with some of those other services. And so you might be hearing people talk, clients might be asking you questions, clients might be concerned about things. So understanding essentially like who is paying for the therapy that your client is getting is really the key to answering that question as far as what risk level you're at.
Mhm. Yep.
Awesome. All right, well, let's move on to using pronouns and general documentation language. Um, and the first one, so I think this will be a little bit quicker actually. Well, we'll see. I don't want to, I don't want to assume. So the first question is any tips for documenting couples work using clients' first initials and they, pronoun for both. And I think specifically with this question, it was that can get confusing when you are delineating two different people and trying to delineate who said what. Um, and my first thought here was actually, really, even if you're working with a same-sex couple, you also have that concern, right? So this isn't specific to using they pronouns. It's really just if you have people who are the same pronoun, how do you delineate them? But I'm curious what your thoughts are there.
Yeah, and I think it does speak to kind of the larger question of how do we remove some of the details about clients from our records in the case that for any reason we did have to turn them over. Specifically for couples work, though, you could number the clients so that you know which is which. And I think this could especially come up if, let's say, you have two clients with the same initials. Like, how are you going to separate the two of them? So maybe you keep your own kind of code or key so you know who is who, but numbering them could be another option. I think some of the other questions we might talk about other ways that you could kind of eliminate the need for that completely. But most of the time, that's going to be for individual sessions. So if you're working with more than one person, couples, I'm thinking even family, how do you know each person? And maybe for yourself, you could create a key so you know who is who.
Yeah. Yeah, I think with a family, sometimes that's a little bit easier if you're saying like mother, daughter, that kind of thing. Um, but yeah, even with my templates in my book, for the couples template, that's what I do. I have like partner one, partner two. And so using that type of language does help you identify who is doing what. Um, but also makes it easy. And this is always my strategy with notes in general. The more you can have written ahead of time, the better the better your notes can be and the faster they will be 100%. So I encourage people to have really detailed templates so that you can go in and just boom, 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 not have to think too much. And ideally, in the templates that I have available, you're not even really typing. I'm trying to think of when you would even type in a pronoun. And so if you can so I will say you can set up your notes that way so that
Mhm.
this is less of a concern. It does take a little setup, right? And thinking ahead, but I think if you start with that, even if you want to just do your own templates, partner one, partner two, and kind of think of it in that way, you can pretty much set up your entire note to avoid even needing to answer that question. Yeah.
What do you, I have a thought for you. If folks are being forced to use like a soap note or something or a DAP note, what are your thoughts on kind of adjusting to that rather than having their own template or being able to build their own thing?
Yeah, I use what I call starter sentences. So if you have to use a soap note, which I personally hate soap notes, I'd like more props to anybody who loves a soap note. Good for you. But they just don't fit with me. And so, but if I had to write a soap note, I would just have starter phrases. So instead of being able to set up your own template, you kind of set up, all right, in subjective, they want me to include this information. So let me set up these little, and you could think of them as fill in the blank. So the sentence is always started for you, and then you're just filling in the blank at the end with the information from today's session. And so that is one way. It's a little bit more time consuming, but it's pretty easy actually. You're just kind of copying and pasting and fill in the blank. So think that's the phrase to remember if you are stuck with a template you don't like, fill in the blank. How can I make this fill in the blank?
Yeah. Yeah, cool. Thanks.
Yeah, thank you. All right. So next question is, are pronouns such as they or them not safe to use in documentation? Yeah, I'm curious what
I,
your thoughts are.
yeah, this question did kind of make me pause. And I think even in my training, we talk about like that would be a suggestion to kind of remove any of the gendered pronouns as using they, them. For me, if you're using they pronouns, like a gender neutral pronoun across all clients, then it stands out much less. You could, if you wanted to, and you've already alluded to this, if you want to remove all pronouns together, you can. So you could just use the word client, or like if we're talking about multiple people, client one, client two, partner one, partner two, parent two, child one, two, three, four, five, whatever it is, just kind of, and that can, I know it feels tedious because it feels like you're repeating that over and over again, but that's the way to completely remove pronouns. So
And you can use
that's an
people's names, like you can use their name too.
yeah. If it's,
Yeah.
I mean, if they're trans or non-binary and they have a different government name than the name they're using, then you might like decide maybe we go back to the initial thing. Like if it's the same initial, then maybe just use an initial. But there are a lot of different ways, to your point, to figure out how to make it gender neutral, person neutral, if that's a term. But I think the most important thing is just doing it across all of your notes. And that way it's consistent and nothing's going to stand out.
Yeah, 100%. And frankly, it's just easier, right? Like
Mhm.
from your own perspective to just always do notes the same way for everyone. Um,
Yep.
when I started, I always just said client about everybody, and so that's still how I do a lot of my examples, because that's just what has been ingrained in me. But it does kind of make everything neutral and fairly easy. It makes your notes feel a little more report-like, but there's nothing wrong with that. And if your concern is sensitive information, that's often a better strategy anyways. Um, let's see, I had another thought there that I was going to say, and I don't remember what it is. So I let myself get on a tangent. I swear I took my
It'll come
medication,
back.
people, but
It'll come back.
um, all right. So yeah. Oh, my other thought was, this is something that I think oftentimes that I will see therapists take on a lot of the anxiety around these issues, even if your clients haven't expressed that anxiety. I think if you're working with trans and non-binary clients, that is very likely something they are already concerned about. Bring it up with them,
Mhm.
right? I really think that here, if you're really struggling with what to write, talk to your clients about it because they're probably thinking about it too. And so let them know, hey, have you had any concerns or have you thought about this? I know that, I take notes about what we do. Do you have questions about that process? You can even make that part of your intake process. I don't think you necessarily need to have it be a question ahead of time, but when you meet with people, you can say, I take notes about what we do. How would you like me to refer to you in your notes? Or you can say, I refer to everyone as they because it keeps it very simple for me, right? But including the informed consent piece here, I think is very important and respectful.
Mhm. Absolutely.
Yeah. All right. So last question on this topic is, when the core focus of therapy is the distress, experience, confusion, fear, etc., of gender identity concerns, are there legal and ethical ways to document addressing symptoms without over-informing about gender identity issues? Is it enough to say identity, authentic self, etc., without mentioning specific gender identity labels?
And the short answer to the question is yes. So yes, you absolutely can. And one of the phrases that I use is just identity exploration. So instead of gender identity exploration or insert whatever here exploration, just identity exploration. And I also think that this question sets up another option, which is to focus on values. With what I do in acceptance and commitment therapy, like everything we're doing is around values. So maybe it's about being genuine or authentic or something like that. Then you're leaning into a value rather than even like an identity exploration.
Yeah, absolutely. And that's exactly the same advice I've been giving for years. I think this used to come up more often, like I said at the beginning, around adolescence and people being concerned that maybe someone's parents could access their records, which is very different in different states. And so this has always been my like, what teenager is not confused about their identity at different points in time, and like documenting about talking to a teenager about identity is no big deal. Um, and really that does apply across the lifespan. Yeah. I love that. And I think remembering that a lot of, while these are can be very specific to gender identity, and obviously that is a very specific category when you're working with people, um, it does relate to, I think, kind of your point, other human experience things. And so keeping the focus there
Mhm.
on what's happening.
Right.
All right, let's get into technology and AI and all the concerns people have about. I was surprised that we had so many questions about this. I was not expecting that. So this is fun. All right, so first question is, what alternatives exist to electronic health records that are embracing artificial intelligence? So I know
Mhm.
that you had some, but yeah, do you have any initial thoughts there?
Yeah, I think just in general is can you turn it off? So, like, if you do have an EHR that has AI components, can you turn it off, opt out, not integrate it? Many of these I think are actually paid integrations or paid add-ons. So that's a great way to save money too if you don't want to add the AI. But if it is something where it's kind of like forced into it, one example, this is not exactly the same, but Microsoft Office and their like Office 365 online, they now have Copilot, which is their version of AI. And so I've made sure to go into our account and turn that off. I think that's just one example of how you can kind of control it if it is a part of your EHR.
Absolutely. Yeah. Yeah. And those are questions that I always encourage people ask these, the EHR company. Um, can I turn this off? If I turn this off, do you still have access to that information? Because that could be a thing. Um, can I turn it off per client? Because you do need client consent to use AI, regardless of anybody's status. And so, if you have 1 out of 25 clients that doesn't want to use the product, can you use it for 24 people and not for one? I'm not 100% sure all of them are set up with that type of nuance, but those are questions to ask the company. And the more you ask those questions, the more they will understand what common concerns are of their customers. And remember, like, you are their customer, so they want to keep you and they want to know those things. And I have seen a lot of these AI companies, at least, um, respond positively to that, meaning that if they see a ton of therapists are concerned about an issue, they will prioritize it and they will make sure to address that and shift things. So do that. Also, I will also link underneath here. I have a handout on considerations if you're using AI. So that gives you other questions to ask if you're thinking about integrating that. So kind of related to this is, are there any EHRs that do not use AI? And you actually had far more information on this than I actually have. Because
Well,
I've been so
just
focused on the AI companies and not the EHRs.
right. It's amazing what a quick Google search will do too. So don't feel like I'm special in any regard. Like you can definitely do the search too. I think one of the EHRs that does not have AI incorporated at all right now is therapy appointment. They do note in like their frequently asked questions that they do plan to integrate AI. They're just figuring out the best way to do it. So right now they seem like the only one that doesn't have it integrated at all, but they do plan to. Intake Q is one of those where you can purchase the AI integration. Jane is another one I hear a lot about. You must opt in to that one. I think if you might actually have to opt out. There was some changes in like people before this date had to opt in, but people after this date had to opt out. So just make sure you're opting in or out, whichever way. And then Theranos became Insora, is maybe how you pronounce that. And you can turn off the AI aspect of their EHR. Um, Simple Practice is another one where you can purchase an AI add on, so it's not automatic. But I think, sorry, Simple Practice, I think that they're a really good example of it's not just about turning it on or turning it off, adding it. Still look at their terms of use and what they're doing with the data, because even if you're not using their AI, they are still using the data in there as a part of like marketing and things. You can read it yourself. You can look at their terms, specifically 9.2 license to user data, and see all the things that they can use user data, which for our purposes, user data is basically that protected health information that HIPAA talks about. So just be aware of that. If you're using that EHR or any of the EHRs that you use, look at the privacy notice, look at the terms of use, and just as you mentioned, ask them about it. What does this mean? Can I opt out of this? How does this affect clients? And for me, a rule-oriented, detail-oriented rule follower, what is the definition of the term? So I went and looked at what does user data mean to Simple Practice in their terms of use. So I think that that's important too, to differentiate between our data as providers and what we are inputting into the system versus our clients' data and what they are putting into the system. And there can be a difference there.
Yes, absolutely. And another one, there's a great article from Person Centered Tech I will link to below this, that talks about the difference between anonymized and de-identified data. And de-identified is a legal term because it's in HIPAA that has very specific requirements. Anonymized is not, and that is often the term that you will hear tech companies use, and they will be used interchangeably, even though they do have different legal definitions. So the concern is that maybe the tech company is using anonymized to talk to you to kind of appease your concerns, but not actually protecting the data in the way you are assuming they are.
Yeah.
Um, so, and that goes back to, I think, like a point we wanted to iterate here as well, which is you really need to read these user agreements. Um, I know that is not what everybody wants to do. That's not what you want to hear. It's not fun, but it will, I think it's good to get a little anxiety from some of those things you can't answer. And then it doesn't mean to like that everything is terrible. It doesn't mean you can't use it. It does mean follow up, like you were saying, whether that's a quick Google search in some way to see if you can get some other piece of information that explains it for you, or whether that is reaching out to them specifically. Um,
Mhm.
I do think that to this point, to this question specifically about are there any EHRs that don't use AI? I don't think that's going to be the case in a couple years. So, um, I my belief is genuinely that AI is here. Um, some people may not remember that, like, I have been trying to get people to use EHRs for years. Um, and nobody like so many people were not into it. It was still pretty 50-50, paper versus electronic records until COVID happened. And then everybody got online, right? And then now it became a completely different thing. I do still recommend paper in some situations, and there's a question about that. But
Mhm.
um, you know, my point is that this stuff does get normalized, whether it's good or bad. And so I don't think in 10 years there are going to be the concerns about AI that we have now. Hopefully there will be some regulations to help with that as well. Um, but my point here is that it's not something to hide from. It's not something to try and avoid. Instead, this is a very unique time, especially with these companies. It is literally within the last 6 months that all of those EHRs have made this accessible. So this is when they want your feedback. Give it to them. Like, be a part of the process. They will not care about your opinion in 3 years, but they do care about it right now. And so you really do have a lot of control and power in how we shape how this looks in a lot of these EHR systems. And they will respond to one another, right? So if you don't really like the way one of them is implementing terms and conditions, and you make that very well known, a lot of times another one will react to that and purposely make different terms and conditions to try and get those customers. So, this has literally happened in the last few years. So, without naming names publicly, but this is something that you can influence. And so use this point in time to do that by making your concerns known, asking these questions, um, and being part of the process. Yeah.
Mhm. Mhm. And we had an example of that with Zoom. A lot of people were using the Zoom for Healthcare option. They came out with their new terms, which pretty much everyone was copying and pasting, saying we can use anything, anytime, anywhere, any way that we want to. And everybody with the healthcare version were like, excuse me, like, what are you saying? So they did have to roll back some of it. I'm still not 100% comfortable with everything, but I adjust my usage to fit what I am comfortable with regarding Zoom. So they do listen to us and they do make changes. We just need to tell them.
Yeah. Yeah. Thank you. That's such a good example. Yeah. And frankly, sometimes these are tech companies. They are not clinicians. Um, and sometimes they frankly just don't know. And it's a completely different culture, like professional culture that they are in. So, just let them know. All right. So related to, I kind of alluded to this one. Should we be using paper notes as a way of avoiding data breaches or online surveillance? Yeah. Do you have any opinion on this, Dana?
Again, the short answer here is yes, it can help to protect against any data breaches, any online surveillance, because the records are not connected, they're not as accessible, but it doesn't protect from a subpoena or a court order that we were talking about earlier. And the other piece that may not apply, well, likely doesn't apply to everyone, but does apply to many of the providers in my state is, again, if you're using state funds for patient or client care, you have to be a part of the NC Health Connects background where the EHRs are supposed to connect to their own like platform through the state, so that and it's not all the data, so it's not like they're pulling notes, but they are pulling demographics and other things like that back into their database, which is run by the state. So again, we're hoping that it's super secure. We're hoping that those connections are being maintained in a way that they should be with the level of data that's going between them. But my understanding is if you are using some of these policies like the state health, if you're a state employee and you're using the health plan for your insurance, and then that provider has the EHR, it has to connect back to this. So that also limits the types of EHRs that they can use. There's a list that the state has put out saying these will work. These are the ones that you can use. So for some folks, it may not feel like an option. But if you do want to use paper, I have done that in the past when I worked within like a hospital system and I had clients, we were rural and they were worried because they're like, hey, my neighbor works in that clinic and that clinic is also connected to your same EHR because the whole hospital system uses it. Like, I don't want my neighbor to just go in and search for my information and look at it. Which, would that be right or legal? Probably not, but they could. There was no extra wall of protection, even with mental health care. There was no extra wall of protection other than you had to basically say why you were going in to access the notes, but they could still access them. So long story short, I still used paper notes for those clients who did not want their records in the EHR. So consent, to your point, again, talk to the client. What are they needing? Can you take their health insurance if you use paper notes? Like, let them make the decision rather you making it for them.
Yeah, absolutely. And I will also add that this is something, ironically, that I have been recommending to more people just for like efficiency and ease. Because if if you're getting caught up in all of the clunkiness or options and all the things that have to do with being online and having online records, I do think it can be very helpful to still use a practice management system for things like billing, and if you're working with insurance, et cetera. But there's no reason you can't do what's called a hybrid record and have your progress notes just be on paper and separated from that system. Um, and so, and frankly, a lot of times that's easier for people. If you have a template that is kind of preset and is fairly detailed and gives you lots of options to just like circle things, check things off, write in a couple notes, um, that's way easier to do on paper for most people than it is to do electronically. So I think there's nothing wrong with having a hybrid record, um, and it might actually make your notes faster. Yeah. Awesome. Let's see. There was one thing I meant to mention in the last when we were talking about EHRs and using AI and all of that. I would say one big thing that I want to highlight is deletion, and asking about, can you delete information? So not just like, is information saved, but sometimes depending on what platform you're using, you might be getting a transcript, you might be getting a summary, you might be getting the progress note, you might be getting all three of those things. And so are all of those things deleted once you finalize a progress note? Is that deletion automatic? So some things have, some systems have things set up so that that deletion happens monthly or weekly or whatever. But that is a really, really helpful thing to be aware of, because as long as the information is deleted, and not saved elsewhere, and you would just end up with the finalized progress note, to me, that's less concerning than if we have full transcripts of sessions for somebody potentially being out there, and to make it even worse, part of the medical record, right? Right. Let's see here. I think we just have one other question, and then we'll finish up. What are best practices for keeping physical records and or external hard drives instead of using an online EHR system? And yeah, I mean, that's it. And I would point you to, honestly, if you want to go that route, totally fine. Do remember, I see your notes here, Dana. I have personally known people who have had their laptops stolen and they had client records on it. I have personally known people who've had their office flood, all their records were gone, had their office completely burned down, everything was gone, and people who have had their offices broken into and paper files were like literally open still, and you have no way of knowing if something was taken, who looked at it, what, right? All of those things still happen. So don't assume that going to paper gives you no risk. There's always some risk, and it's more important to look at what risk am I comfortable with and how am I mitigating that risk regardless of the scenario, right? That's really the best consideration. And person-centered tech has amazing resources about all of these things. They will walk you through, yeah, how do you do password protection, how to know if something is encrypted. So if you want to move into more like hard drives and instead of software, they are an excellent resource for how to do that well. But did you have anything else to add there?
Yeah, I think a fireproof, waterproof cabinet of some sort, whether you have paper, like written or printed notes, or if you have like those external hard drives and you're not saving it in like an EHR or an online drive of sorts, then having that water and fire proof area that can also be locked is really, really important to have. And that's where we stored our paper notes in the office that I was in. It was a big cabinet that each of the drawers had to be locked or unlocked, and it had like hanging files, and it was fire and waterproof. So that's going to ensure that any of your physical files are safe. If you're worried about the repercussions of your EHR getting hacked, or client data getting hacked from like an online drive or something where it's not external, but it's internal to some other system, cyber liability insurance is going to be your best friend. It's not going to prevent anything from happening, but that will help you in the case that that does happen. And I'm sure we've all had this unfortunately happen to us, where our data has been a part of a breach and we receive that letter that says, hey, if you want to receive credit monitoring, go to this link, use this password, and you can have credit monitoring for a year or whatever. Here's what we're doing to improve and fix what we've done. Cyber liability helps cover those costs, to retrieve the data, to send out notifications to all of your clients, to re-up your security and whatever that looks like. It unfortunately does fall on us. This is pushback that I often hear is like, well, that's on the EHR or that's on Google or that's on Microsoft. And it's actually not. Like, that's part of the contracts that we sign, especially if it's like, because maybe we use the same password in more than one place and it got hacked. Or like you said, the laptop gets stolen and we've got files just chilling in a folder or something. Any of that cyber liability is going to help to mitigate some of the costs associated with it.
Yeah, that's an awesome tip. Yeah, thank you for that. So I know more things to research for everybody. Um, but really, with a lot of this, and this is why I love the approach that person-centered tech takes with a lot of these things, there's no such thing as no risk with all of these things. And so a lot of it, I always go back to client consent, right? Talking with your clients about what risks there are. And then identifying like what is most important to you, because answering those questions will create different answers for different clinicians that are all right, based on what it is that your needs are. Let's see. And then you shared an article here. I don't know if you want to share a little bit about what that is, and we'll link to that in the description.
Yeah,
um,
this was just something, again, while I was searching, where it's happening more so with quote physicians. So think like medical doctors, true MDs. But it is starting to be extended to our fellow allied health professionals, such as OT, PT, speech language pathologists. I didn't find our specific field in there. So just be aware, I'm sure it's coming, that essentially there are some laws and acts that they are holding us to related to AI and our EHRs. So there's some, essentially, it may fall on us. If AI harms a client, then it may eventually fall on us. And they are restricting and getting more detailed about what our responsibilities are regarding using AI. So again, our like field was not listed in what I found through the government website, but that doesn't mean that we're not next.
yeah, absolutely. And Illinois passed a law specific to mental health and AI use, and that
Mhm.
mental health clinicians, um, they can use AI only as an assistant. You cannot use like an AI chatbot to pretend to be you or to help clients as you. You cannot use it for documentation and then not look at the documentation. They really identified that a clinician has to make final decisions and have oversight over anything that AI touches related to client care. So that is now a law specific to any of us who would be in Illinois or treating people in Illinois, essentially.
Right.
Um, yeah, so these things are definitely coming. Yeah.
And that it's interesting you say that, because I found that I know some of us use like doxy.me for our like telehealth visits, and they have a new chat bot on there that is like AI, that's supposed to assist providers. And now I'm wondering like how might that apply with that new law in Illinois? And I know that some of y'all are thinking, well, I'm not in Illinois, or I'm not licensed in Illinois. We've got the compacts coming. So if even if you have a privileged license in Illinois, you're responsible for knowing that state laws. You're going to be responsible for adhering to that law too. So thanks for bringing that up, because I didn't know.
Yeah, I mean, it's very new, and that's the thing. All of this stuff is changing rapidly, but I think it is helpful to see some of these first things that are happening, and they're really in response to, people harming themselves as a result of talking with AI or using AI and thinking that they're getting some type of mental health support from that. And so I do think because the stakes are so high in that way, we will see this continue along those lines. Um, yeah. So, and I think that's a good thing. Clinician oversight over
Right?
over AI.
Who doesn't want
Yeah.
that?
All right, we have gone over time. I thank you so much, Dana. Thank you, everybody, for being here. We will, put comments, questions in the comment section. I'll keep monitoring those. We can direct you to those resources. Dana has a training on this, and so you can absolutely get some CE credit and dig into it more. Yeah, did you have anything last that you wanted to share?
No, I mean, folks have said, in the chat, like, thank you for doing this. This is a great discussion. I don't see any questions, but to your point, if y'all have questions, like, we are both amazing resources in our own ways. So reach out to us, and if we need to refer to the other, we will. But don't let this be the last time that you think about this. Continue to have this discussion with us and with your colleagues so we can better figure out how to serve trans and non-binary clients.
Yeah, yeah, absolutely. And it's okay if you heard something, you're like, oh my gosh, I haven't been doing that, you can always just start today and you're here because you care. And so I think that's really, really important. Talk to your clients about it and just keep seeking those resources. All right, thank you everybody for being here. I gotta figure out how to stop the YouTube, how to stop the streaming. uh, now that I've figured out how to do the stream. Oh, there we go. All right, we'll go ahead and stop our stream. Thank you all for being here. Check out the resources that we'll link below in the description. All right.